Hello everyone, and welcome to the webinar, Living and Working in the Coverage Gap, Homeless Healthcare in States Yet to Expand Medicaid. My name is Dan Rabbit, Health Policy Organizer at the National Healthcare for the Homeless Council, and I'll be moderating today's presentation. The webinar is a production of the National Healthcare for the Homeless Council with support from the Health Resources and Services Administration, Bureau of Primary Health Care. This session is being recorded and will be archived on our website at www.nhchc.org. This is a 1-hour presentation with the last 10 minutes reserved for questions and answers. We have an excellent group of presenters today. Again, I'm Dan Rabbit. I'm on the Council's policy team, and I'm based out of the Healthcare for the Homeless Project in Baltimore. We also have Judy Solomon, Vice President for Health Policy at the Center on Budget and Policy Priorities here in Washington, D.C. Very excited to have her. Jen Hyvanen, HCH Director and Communications Director for 4th Street Clinic, HCH Project in Salt Lake City, Utah. We have Monique Winters, Community Resource Specialist and the manager of their Certified Application Counselor Program at St. Joseph's Mercy Care in Atlanta, Georgia. And Jeff Driver, a member of the Consumer Advisory Board at Downtown Clinic in Nashville, Tennessee. So with that, I'm just going to jump right into the presentation. I'm going to frame things up for everyone and then pass it over to our fantastic speakers. This webinar really came out of a project that we did for HRSA to go over or explore the impacts or lack of impacts of the Affordable Care Act and the decision to not expand Medicaid in the states that haven't expanded yet. We chose to do that project because Medicaid expansion has such a tremendous impact on the provision of homeless health care. Prior to the ACA, most people experiencing homelessness were uninsured. I believe in 2013, at least for patients at Healthcare for the Homeless, I think 62% of the patients we saw were uninsured. That percentage had gone down in the years running up to 2014, thanks to some early expansions from the Affordable Care Act. But the vast majority of people experiencing homelessness did not have insurance. That complicated treatment and access in a variety of ways that we'll get into. With the Affordable Care Act, Medicaid expansion really is the main opportunity for new coverage because the other main avenue to getting new affordable coverage through the Affordable Care Act is purchasing a subsidized private insurance plan on a state or federal marketplace. In order to be eligible for those tax credits and those subsidies, you need to earn at least 100% of the federal poverty level, a little under $12,000 a year for a single adult. And most people who are experiencing homelessness don't make that kind of money. So if you don't make about $12,000 a year, but you're in a state that hasn't expanded Medicaid, there is what has been being called a coverage gap, where you can earn too little to qualify for subsidies, but earn too much or not qualified due to the categories of the Medicaid program, like you're not disabled, or you're not pregnant, or an adult with a dependent child, things of that nature. So that's why Medicaid expansion is so important to homeless health care and why we decided to embark on this project. The way that we worked on this project here at the Council is we interviewed 3 different groups of people in 5 states. We interviewed Healthcare for the Homeless leadership, including both administrative leadership and clinical leadership. That was one set of folks. We interviewed enrollment staff and frontline workers, and then we also interviewed consumers. The 5 cities that we interviewed people at were Atlanta, Georgia, Mercy Care. We have Monique Winters from that shop on our webinar today. Houston, Texas. We interviewed folks from 2 different Healthcare for the Homelesses there. Manchester, New Hampshire, which has now become an expansion state, which I think is fantastic. But at the time of the interviews was still a non-expansion state. They're the most recent state to implement the Medicaid expansion. Nashville, Tennessee, where Jeff is from, and Salt Lake City, Utah, 4th Street Clinic, where Jen is from. We conducted a total of 19 interviews. 17 initially, and then 2 follow-up interviews with New Hampshire stakeholders after they had decided to expand Medicaid, just to get a kind of before and after shot of that. And the topic of the interviews really focused on how Medicaid expansion, or the lack thereof, impacted the finances of healthcare for the homeless projects, how the billing capacity and enrollment systems that those projects had worked or didn't work, and what they needed, what folks thought that they needed to develop, what clinical barriers existed or were exacerbated even by the fact that the states had not expanded Medicaid, and what was the consumer experience like of being screened for enrollment and in all likelihood not being found eligible for any new coverage. This is just, we're going to talk a lot more about what we learned and what the themes were with our other presenters. But this is just one graph that we pulled out from the work that we did and the interviews that we did. And this shows insurance status at the time of visit for patients at 4 different healthcare for the homeless projects. That red line that looks very flat and never approaches even 10% of people insured is Atlanta. The green line above that is Houston. And then New Hampshire and Salt Lake City are not quite as flat as the other 2. New Hampshire, it makes sense because they were about to expand Medicaid and then did expand Medicaid in August of 2014. So that explains that little uptick. But in Salt Lake City, you see an uptick as well. And that wasn't because of any policy changes in Utah. Utah is still a non-expansion state as of right now. But that, we think, is because of improved enrollment systems and improved screening processes that 4th Street Clinic instituted, despite the fact that Utah had not expanded Medicaid. So there are still opportunities, even in states that haven't expanded Medicaid, to try to improve access for the people that Healthcare for the Homeless projects serve. So with that, I'm just going to pass it over to Judy. That's a quick overview of our project, but we're going to get into more of the details in just a moment. So I'm going to hand it over to Judy Solomon from the Center on Budget to give us a view nationally of how Medicaid expansion is going currently. Judy?
Yep, thanks Dan. So I'm going to start with the map, and I'm sure many of you have seen versions of this map, and the states that are blue are the states that have expanded, and then we see Pennsylvania in stripes. Pennsylvania's expansion will take effect in January, so that's a big deal there. In terms of what else is going on, there's a number of states, and we'll talk a little bit about them, that have live discussions going on around expansion, including Utah, Wyoming, Indiana, where there is a waiver proposal pending, North Carolina, and Montana, all states, and Tennessee, all states where there is at least some discussion, although it's not clear that any of them are going to expand in the next few months. So this is just to kind of ground us on where we are and what this coverage gap looks like in the states that haven't expanded. The blue shows, the dark blue shows what it looks like in states that haven't expanded. In states that did expand, the slide would actually be filled in all the way. So in states that, in expansion states, all adults up to 138% of the poverty line are covered. But if you go to the right and see what it looks like for adults, both parents and childless adults, that's where you see the coverage gap. So under current Medicaid rules, parents, low-income parents of eligible children can receive Medicaid. However, that income eligibility is very low, less than half of the poverty line, compared to what they would be able to qualify for in a state that took up the expansion. So the coverage gap is very real. Now, even in the states that haven't expanded, people with incomes over the poverty line can get the premium tax credit. So the coverage gap really is that white area, the area that's kind of shaded blue. There is an opportunity for coverage although people would have to contribute to the cost. All right, so let's transition and let's talk a little bit about how some states are expanded. And again, I think it is important to have a little bit of grounding. So I hope this isn't, too technical. But we often hear about Medicaid waivers. And in the state that I came from before I came here to D.C., which was Connecticut, policymakers would often say, oh, we don't want to do that. We don't want to do something in Medicaid. Let's waive it. So there's this sort of using waiver in that way gives people the idea that, you can just waive anything if you don't like it. But that really isn't the case. A waiver is really a demonstration project. And there is authority in the law for states to do demonstration projects in Medicaid, and they've been doing these for many, many years. But a demonstration project has to be intended to basically enhance the objectives of the Medicaid statute, which is to provide health care to people who otherwise wouldn't be able to get it. And if you're in a demonstration project, you can waive, and that's where we get the waiver, certain provisions in the statute, not everything, but certain provisions, but only to the extent you need to do that to carry out your demonstration. So there has to be a connection between what you're trying to do and what provisions you're waiving. And we're going to go through a couple examples, and that maybe will get a little more real as we go through it. Another important thing about waivers is that the federal government isn't going to let states do things that are going to cost it more. So the federal government pays part of the share on average for before health reform, about 57% of the cost of covering people, and the states pay the rest. Under the expansions, the newly eligible people, that federal share is much higher. It's actually all of the costs for 3 years, and then it phases down to eventually stop at 90%. And that's where it will stay starting in 2020. So, for the expansion, the federal government is paying almost all of it, and they're not going to pay more than they otherwise would through a demonstration project. And then also very important in our transparency requirements that were added in the Affordable Care Act in health reform that allow the public to have input both at the state level as the waiver, as the demonstration project proposal is being fashioned, and then again at the federal government when it is sent over to the federal agency at the Department of Health and Human Services, there's another opportunity for the public to weigh in. And those were very important protections because in the past, waivers had often been sort of negotiated by states and the federal government without any public input. So where we are now in the states, when you looked at the map, you could sort of see the states that have expanded. Many of them are what we would call blue states. The Supreme Court made its decision that said that whether states expand Medicaid is an option. It couldn't be required. And it was very clear right away that New York and California and Vermont, states that had a history, Minnesota, of providing coverage even beyond any Medicaid requirements, that they would, they'd be in. Connecticut, the state I'm in, I had no doubts I'm from. But there obviously are now the states where they haven't expanded. It's a little more different. The politics are different. And what we're seeing then are, states really saying, we're going to do it, but we're going to do it our way. So I've just listed here, the 4 demonstration projects, expansion demonstration projects that have been approved so far, and then what's kind of in the pipeline. New Hampshire has expanded, but part of its plan to expand was that they would have to follow up with a demonstration project. So that is about to be submitted to the federal government. But you can see some themes in the names of these, and that's what I really wanted to talk a little bit about. You see private option, Arkansas using the plans in the marketplace to provide coverage to the newly eligible people. And in Arkansas, that was the state that covered the fewest adults in Medicaid. And they also had a solely fee-for-service program. They had no managed care. And I think in part this use of the private plans in the marketplace was because they knew they wouldn't really have an infrastructure to absorb the newly eligible people. Many states already provide health care through private managed care plans. So I think, it's important to sort of understand, why Arkansas went in that direction and why, this sort of notion of private coverage is not that radical because most states are using private managed care organizations to deliver services to Medicaid beneficiaries. Personal responsibility is a biggie. This whole notion of people have to have skin in the game. They have to pay. They have to contribute to the cost. We'll talk a little bit about what the guardrails are on that, but I think the other thing that's really always important if we think back to these being demonstration projects and trying to show something innovative is that we know a lot about cost sharing and premiums in the Medicaid program and what the impact is. And we know that, co-pays for very low-income people make it less likely that they get necessary care, that it doesn't just keep people from going to the doctor when they really don't have to. It keeps them from going when they do have to. We know that. We also know what premiums do for very low-income people. They depress participation. So that's why, for me, it's always really important to keep in mind that these are demonstration projects, and we're supposed to be proving something. The other thing is using incentives for healthy behavior. So in Iowa, they actually have been allowed to do some premiums, but if you go and get a well adult exam, if you get certain preventive services, the premiums can be waived. So it's this notion you wouldn't have to pay them. So it's this notion that we'll use premiums as a way to get you to engage in healthy behaviors. And then I think there really is, and this is showing up right now in Indiana, pushing on the limits on what the authority is, because what Indiana wants to do is not only charge premiums, but to lock people out for 6 months if they don't pay them, and that's, something. And a lot of states have been looking to impose work requirements. To date, what the policy has been is that Medicaid is not a work program. It's a healthcare program, and that, in the context of a demonstration project, this is not an appropriate thing to demonstrate using Medicaid as a lever to get people to work, although I think we're going to begin to see a little bit of movement on things that are connecting the benefit to work, but not to the extent of cutting people off if they don't engage in work search or other activities. There are limits, and I'm going to go through this pretty quickly because it's a little bit technical, but I just wanted you to know kind of what we know. So as soon as the Supreme Court made its decision, people started asking, well, could a state expand just up to 100% of the poverty line and not go up to 138 because people between 100 and 138 can get coverage through the marketplace? And the answer really has been, well, you could do that. That's what Wisconsin is doing actually right now. They're a non-expansion state without a coverage gap. But if you do it that way and just cover people up to the poverty line in Medicaid, you're not going to get that special match. You're going to still get your regular lower match ranging from 50 to 73% depending on the state, to cover the people below the poverty line, and that's what they're doing in Wisconsin. And then everybody above the poverty line goes in the exchange. Cost sharing. Remember when I said that only certain parts of the Medicaid statute can be waived? Cost sharing is one of the ones that you actually cannot waive except under very, very, very limited circumstances that are, we don't have time to go through them, but they're almost impossible for states to meet. So cost sharing, there is a lot of flexibility in Medicaid for cost sharing, particularly for people with incomes above the poverty line. And you can charge a copayment for a doctor's visit or a hospital stay, but you can't make it higher through a demonstration project. It's pretty much baked into the statute. And then this is the third one. It was a letter in Iowa, and they actually did go back on this a little bit. They have allowed Iowa to have premiums, although they haven't been implemented. As I said, they can be waived for healthy behaviors. They also can be waived if somebody says they would have a hardship paying them. But the premiums for people below the poverty line, if you don't pay, you can't be cut off. So, and as I said, they haven't really gone into effect, and work requirements have never been approved in Medicaid. And then I'm not going to really go through this because I want to get to the arguments. This is just sort of the outline of what states can do under these Arkansas-style projects, and you can have that in the slides. And if people have questions, you certainly can get in touch. But I wanted to just go to two things. Just, how do you rebut some of the arguments that are made against expansion? And then some positive arguments that I think we have now based on what's happening in the states that have expanded. So you've all heard this. You've heard the myths about Medicaid. Opponents rely on all kinds of claims that you don't have any access and all kinds of things. Some of this is from, actually all of this is on our website, either in the blog or in papers. Lots of material on this. But, people say Medicaid is wasteful, it's inefficient, people go to the emergency room instead of going to the doctor regularly. The evidence really shows differently. There also is the claim that, we don't want to do it because, we can't do it our way. But, as we've already seen, and there is a lot of flexibility. And there's a lot of flexibility in how you deliver services. And right now, I think there's some really exciting things happening in the states around patient-centered medical homes and pairing, and I know this would be something, near and dear to you all on the phone, working on, housing and how do you sort of deal with social determinants of health. The current administration is very, very interested in these issues and having Medicaid be kind of the hub for a lot of other efforts to improve people's lives. And I think a lot of them really mean, to carry them out, you need to get the low-income adults covered who haven't been covered before. So I think there's a lot of flexibility. There's a lot of exciting things going on. The other big one is the financial argument. It's going to cost us too much. Yes, they say they're going to pay for the entire cost, but they really aren't. And the stability of funding in Medicaid is historical. They've really never changed the match rate, other than to give states some extra money when in recessions. And so I know I only have about 2 minutes. So let me just say a couple things about what we're seeing in the states that have expanded and happening much quicker than I would have anticipated. Big decreases in uninsurance. The Urban Institute has been doing a monitoring survey, and in the states that have expanded, we're seeing a drop in uninsurance from 16 to 10.1%, and in the non-expansion states, only from 20 to 18.3%. Those states, you see, they're actually starting in a worse place. They're starting at 20, and the expansion states started at 16. So, it's really reinforcing inequities that were always there, but in states that haven't been able to get expansion over the finish line and close the coverage gap. And then I think the evidence from hospitals is amazing. I mean, tweeted an article from the Des Moines Register on Iowa Hospital Association saying, what had happened there. I think it was a 46% decline in the number of people they're seeing without insurance. And we don't have time to go into some of the other really ways that states are saving money. So I'll just say that the budget growth of state Medicaid spending is actually slower in expansion states, and many states are booking savings in their budgets for mental health and elsewhere. I think in addition to booking savings, it's really important to understand that, and I always sort of say, yeah, you can book savings by substituting federal funds for state funds you're spending now, but you also have to think about it from the perspective of how does this allow you to enhance what you're doing in mental health and increase the capacity. And I think that's really important. So I'm going to stop. This is just some contact information, and I'm going to turn it over now to Jen Hyvanen in Salt Lake City.
Hi, everyone. I'm Jen Hyvanen, and I work for 4th Street Clinic out in Salt Lake City. We are a standalone HCH that has been around for 25 years. We're now a AAAHC medical home. And in 2013, we operated with a staff of 150 volunteers, and we provided 25,000 medical, mental health, substance abuse, dental, pharmacy, and case management visits to approximately 4,100 patients. And as you can see, our patients are the coverage gap. 74% remain uninsured, and the vast majority of them are below 100% of the federal poverty level. Our operating budget is roughly $7.2 million, with nearly half of that coming from in-kind and 20 to 25% being revenues produced from private fundraising. So our revenues from reimbursable services are very low and vary somewhere between 4 and 7%. So we do operate in a non-expansion state, and as we say in Utah, that being enrolled for Medicaid, getting enrolled in Medicaid, and getting reimbursed for Medicaid are really 3 different processes that we're working really hard in order to streamline so we can promote better health outcomes in the future. So themes among non-expansion states are appropriate care is complicated by a lack of health insurance. So there's still a lot of emergency care, 911 care, and patients who really have fragmented care where you don't have that comprehensive history and comprehensive primary care. Very difficult still to get inpatient treatment or specialty care. In Utah, a lot of that is done by volunteers at 4th Street Clinic, and there's a heavy reliance on HRSA grants, volunteers, and fundraising. For example, our volunteers can pose some difficulty because FTCA still does not cover malpractice for those volunteers, and so we have had to go through a specific state process in order to get that covered so we can provide services, and fundraising often is an unstable source. Often you're lucky if you get a 3-year grant for private fundraising, and so in order to do it for long-term revenue reimbursed, it makes it very difficult. And in Utah, politicals favor expanding through private options. So we are looking at a premium assistance model. And billing, enrollment and billing processes also will take time and resources to develop. So what we've done is we've had a federal outreach and enrollment grant. And that really has helped us improve our practices on the front end so we can become ready for Medicaid expansion, which we do believe will happen in Utah. So prior, we really had eligibility on the back end of patient flow. It was handled by providers and medical assistants. It was a costly procedure, a little bit inefficient, and very hard to follow through. So we did have a lot of high application denial rates and very long wait times. And we had high claim denial rates as well. So developing enrollment processes, we have resourced an O&E supervisor who manages now the front desk. So all front desk and receptionists are now staffed underneath the outreach and enrollment supervisor. And we've hired several CACs in order to help with that outreach and enrollment process. So we've incorporated eligibility screening into our patient registration. So when patients come in and we're screening them for eligibility at our HCH and sliding fee scales, we're also screening them for eligibility for Medicaid. We also have 2 Department of Workforce Services outreach workers whose offices sit next to the O&E supervisor. So when applications are made and it's in the health clinic, and disability is the main source that we're able to have people covered for Medicaid. We can fill out the application, we can have it signed off by providers really easily, and then walked over to the Department of Workforce Services offices and get it processed really quickly. So what that has done is really enabled us to go from about a 6-month wait to about a 3-month wait in applications. So also, we're pretty ready for Medicaid expansion due to our PCA database. We have an EPIC database where our outreach and enrollment supervisors and the CACs go in and enter in all of the information. If people have been denied for Medicaid, they go over to the marketplace, and then we help where they get denied there, but then we help to make sure that they have the exemption from the individual mandate in order to do their homeless status. But all of that information is then put into the PCA database, so when we do expand for Medicaid, we'll be able to go and revisit those applications fairly quickly. So again, then there's developing the billing process. So we've really had to revamp our credentialing process for our providers in order to ensure that everyone is credentialed not only with the state Medicaid office, but also with all of the ACOs. We've also gone through a Medicaid coding audit in order to identify where we could be coding better and getting reimbursed for those visits. And then we've done a lot of training with our CFO and our billers. One current issue that we do have is we only have 1.5 billers. So as we start to move more towards a reimbursement revenue model, we will have to take a look at that. And a lot of other themes with HCHs is that we operate multiple sites and we use volunteers. That adds another layer of difficulty to get reimbursed. So next steps are we really need to take the O&E beyond the clinic walls, not just going patients who come into 4th Street Clinic and screening them, but participating with other partnerships of where our patients could be and getting them enrolled in Medicaid. Also coding and training for providers, and then developing a feedback loop from the billing to providers. We also have really grown. We had about a $2.9 million grant in order to double the size of our clinical space. But that was really used in order to grow behavioral health services such as mental health, substance abuse, and dental. But all of those services are particularly difficult in getting reimbursed for, as there's another layer of bringing in benefit packages and credentialing providers. So currently, we are looking to apply to become a licensed substance abuse outpatient treatment center, which will then allow us to amend our mental health contract and include a substance abuse benefit, which then we would credential our providers and be able to reimburse for those services. So that would be about a year to a year and a half that we expect from when we would be providing substance abuse services to when we would be able to be reimbursed for them. And then also we're looking at becoming a Medicaid pharmacy and dental as well. For Utah and the Medicaid expansion, pros are that we're looking at homelessness, that our homeless patients will have access to health insurance. We'll be able to close that gap and really move people towards health. Another pro is that Utah is having a conversation of including a homeless definition in the medically frail. And we've moved away from the work requirement conversation and now becoming a work option in order to link people into work opportunities. For 4th Street, if there is no expansion combined with the threat of a community health center fiscal cliff in the future, we could actually be looking at a 70% decrease in revenue over the years. So we're working really hard in order to negate these challenges and be sustainable in the future. Now I'd like to turn it over to Monique in Mercy Care.
Thanks, Jen. Hi, I'm Monique Winters. I'm a Community Resource Specialist at Mercy Care, which is located in Atlanta, Georgia. Some of the things among other enrollment staff, like myself, in non-expansion states are that very few individuals experiencing homelessness are found eligible under new coverage options. With Medicaid not expanding, most of these individuals at federally qualified health centers like Mercy Care, they still do not qualify for coverage. We provide education on the Affordable Care Act, other benefit enrollment assistance such as Kaiser Bridge program, and of course explaining other options out in the community. So first, a little information about Mercy Care. We have been serving Atlanta's underserved and underinsured since 1985. We operate 2 clinics in Metro Atlanta area as well as 15 satellite clinics. We have 2 fully equipped mobile coaches that provide different services such as primary care, prevention care, infectious disease, recuperative care, dental and vision services, diagnostic services, and behavioral health. In 2013, Mercy Care saw 12,792 clinic patients. We had over 24,000 medical visits, over 8,000 dental visits, and over 5,000 mental health encounters. Even though we have a lot of visits, over 95% of our patients are still uninsured. 67% of them are experiencing homelessness. So we do see a lot of indigent population and people who really would benefit from Medicaid being expanded in Georgia. Our outreach and enrollment plan from 2013 was that we had 3 full-time staff members that conducted in-reach and outreach at different partner sites. So we had individuals that were housed here in our clinics, and then we had people going out into the community for different community partners like social service agencies, faith-based organizations, health departments, etc. Our goal was to reach all individuals lacking health coverage and at least educate them on the options and let them know about Georgia not expanding Medicaid and what they could do to help. In Georgia, the Affordable Care, there were 316,000 individuals that selected Marketplace plans during open enrollment. We were number 5 in enrollments under the Federalist Facilitated Marketplace. We have the second lowest average premium. The average was $54 with a tax credit. I think the only state that had lower premiums than Georgia was Mississippi. 87% of Georgians who enrolled selected plans with tax credit, and 71% of those selected silver plans on the Marketplace. Of course, those came with the cost sharing. Right here at Mercy Care, we assisted over 6,400 individuals. However, we were only able to enroll a little over 1,100. Out of the 5,200 individuals that did not enroll, the majority of them fell into the gap because, of course, Georgia has not expanded Medicaid. There were just a select few that opted to pay the penalty. Some went with employer coverage, and just a few refused Medicaid. Some of the challenges that we faced from the beginning were just a week before open enrollment last year, which was October 1st, there were licensure requirements that came from our insurance commissioner that required all certified application counselors and navigators in the state of Georgia to be licensed as if they were insurance agents. So that put a hold to individuals going out and helping people get covered from the beginning because we faced these licensure requirements. Of course, the lack of Medicaid expansion has been a big deal here. The website issues, the website not running, or just really giving us problems. A lot of people have a lack of trust in government here. Some of the things that we ran into were people who had misconceptions about Obamacare and the Affordable Care Act, not being knowledgeable about that they're really the same thing. So we had to do a lot of health literacy and explaining to individuals about their options. So we also had to do a lot of education about the impact of Medicaid expansion and what that means for people who cannot get health coverage. So you can have a mother that works, her children can be covered, however, because she falls under 100% of the federal poverty level, she makes too much for Medicaid, but not enough for the Marketplace. So she's left in limbo. So at that time, we would emphasize what services are available to them without insurance, such as federal qualified health centers, health departments, etc. Our future here at Mercy Care is we will still continue educating individuals about their options. We will still continue to help individuals to get enrolled. We'll reach consumers who did not access coverage last year, helping them keep and use coverage. A lot of our clients that came in to get covered have never had health coverage before in their life. So they did not understand what insurance means, what is a primary care physician. So we have to do a lot of education about insurance. Continuing outreach and education throughout our local community, and promoting social change through advocacy, opportunities, and safety net partnerships. For more information about Mercy Care, visit mercyatlanta.org. Now we will hear from Jeff Driver, who's on the Consumer Advisory Board at Downtown Clinic in Nashville, Tennessee.
Hi, everyone. My name is Jeff Driver, and what I am is a consumer of the HCH program in Nashville, which is one thing I wanted to emphasize more so than being a board member or anything else. I receive these services and would be in dire straits if I did not. The first slides they have for us to go over here are themes among the consumers of the program in the non-expansion states. And the first three really could be looped together, and it's misinformation and rumor about, well, first of all, ACA, which Monique very accurately pointed out has been misnamed by political opponents and therefore causing a layer of confusion. The American Care Act was never meant to be called, or never intended to be called Obamacare, to my knowledge. And it's a shame that type of thing goes on, but well, it does. The point that individuals experiencing homeless are found eligible, or excuse me, few are found eligible for new coverage options is a part of a theme, especially in the South, that you know, help is not coming. You just resign yourself to the fact that there'll be little or nothing there for you, so you just use the emergency room. That's what it becomes the means of coverage for anyone. Grinding intractable poverty can lead to a mindset that says that we need only do anything when we have to, and when we have to, we'll go to the emergency room. It says that consumers are angry because, and they are resigned because they will not receive help. This is true, and that it's something that I've experienced myself and those that I know, is that you know, through years of promises only to be recalled or trimmed by different administrations, it creates a mindset that, you know, one is on their own. And concerns about the current safety net services continuing are very real, because if we're expected to not expand them, then your first belief is that they will be contracted, and that there will be a loss of access, that there will be a loss of coverage, that there will no longer be any continuing coverage. And that is the main thing I want to point out in the last bulletin, is maintaining that strong relationship with the HCH gives the patient continuing care with the same group, rather than the same emergency room. Someone actually has a history on hand of medications, a history on hand of previous injuries and long-term or chronic illnesses, rather than creating a hodgepodge, if you will, of information throughout a city, because there's no real central location to go to. Let's see here. Okay. The downtown clinic, of which I am a client, is something well, at this point in my life is very near and dear to me, because I feel in many ways it is the reason I'm still alive today, and I don't think anyone would disagree. When you look at these numbers here, the 4,500 unique patients for a building of its size, that's a lot of people. The 16,000 patient visits that they see a year. If you give credit to the idea that they have 2 front office people attempting to screen, a couple of doctors, management, a couple of therapists, and a couple of nurse practitioners, that's a lot of people to see on a 5-hour day, 8-hour a day week. It's quite impressive. And since the typical patient, and I fall into this category, has several chronic disease problems, health problems, and receives quite a few medications. The load put on them, the pharmacy and physicians themselves, is staggering. The primary care and behavioral care, all handled right there, are exceptional. Need only more people and more access for visits, so that there isn't as much, perhaps, time between appointments. Dental care, which I have used, is good. I cannot be more complimentary of it. Education, I have not had the opportunity to receive more than what I have through the behavioral health aspect of it, but there are health education things regarding my, as I age, my personal health that I need to know, and I don't know them right now, and they will be who I look to provide them. Transportation and case management, of course, will continue to be issues. Labs and referrals to specialty care are always important, because that is where, in many cases, additional problems are discovered, and the need for additional care is then planned for. Okay, the next slide regarded called My Challenges Getting Needed as far as health care. The first one of the big ones that I faced was the formulary issues. It is, I guess, become and I don't know, because I'm not as knowledgeable as you all, but I kind of throw the baby out with the bathwater on certain medications. And like other medications in the past, that will take some maturation on the part of, I guess, everybody involved. But to deny me a certain medication would then nullify the others that I have to take, because I'm no longer on the playing field, if I could put it that way. This medication is key to my survival, but it's not allowed. So therefore I have to come up with $300 to go to a physician, and $80 for a follow-up, and pay full price. And I have to do this while being homeless and unemployed, which is a challenge. And it's one I'm not sure I'll always be able to meet, but right now I am able to. The TennCare approval, and in Tennessee is called TennCare, I guess, to add to the confusion as to what it actually is. The SSI approval rate is high. I was up to my 14th month when I released my lawyer and went to the SOAR program in hopes of improving the time frame by which I might get it. My punishment for that would be losing all the previous waiting months that I had, which came to several $1,000s. There is a shortage of housing, affordable housing anyway, in the Nashville area. And Nashville is going through a period of gentrification. So things are shifting around. Things that were once worthless are now priceless, and vice versa. So it's kind of a guessing game right now where everything will land. Legal issues and aid are available. However, ongoing legal representation is something someone will probably have to acquire themselves through legal aid, and it's difficult, if not impossible sometimes, to do. And specialty care, last issue there is, of course, a long wait. So this last slide speaks for itself. As far as not earning enough, how can that possibly be true? It's anti-intellectual. It reminds one that if you look at the state map that was shown earlier, from Missouri over, it very much resembles the one that was dividing the states during the Civil War. States' rights is a good thing. Sometimes it's not always a good thing, and not everything expressed here is the opinion of the HCH or its membership, but rather me. Having skin in the game, someone said, my skin is the skin in the game, and it would be outdoors and unmedicated right now if it weren't for the HCH program. Expanding it is essential. Why it is being so convoluted, I don't know. We're replicating 23 different states with the same issues. Good luck. Thanks.
Well, thank you so much, Jeff, and thank you to all of our presenters. I think that really gave us a much clearer view of what it's like to both run a homeless healthcare clinic in a non-expansion state, provide services and enrollment assistance, and what it's like to be a patient in those states. And so hopefully that did come through loud and clear, and we really appreciate all of your time. Before we jump into questions and answers, I did want to highlight one thing. We have a new policy brief coming out on this topic, same title as the webinar. It is available to download. And so we have a few minutes for questions and answers. First question I'm going to send to Monique. It asks about our high deductible bronze plans causing a rise in bad debt due to newly insured people not being able to pay their bills. Bronze plans are the lowest actuarial value private plan available on the marketplace. And as Monique's Healthcare for the Homeless project serves a lot of people who make a little bit more money than the average person experiencing homelessness. Maybe she might know a little bit about that. Monique, what are your thoughts about that question?
So, yes, the bronze plans do have the highest deductibles and the lowest coverage on the marketplace. However, in my experience, I have not had one individual select a bronze plan because the silver plans are offering higher coverage, lower premiums. A lot of times, based on their income, they're getting free premiums. So they're getting a plan for free. So I have not had anyone select a bronze plan.
Mm-hmm. Okay, that's good to know. Yeah, aren't the premium subsidies, the financial assistance, isn't it based on like the second lowest cost silver plan or something like that?
Yeah, so the silver plans are the ones with the premium assistance, the subsidies, and the cost sharing. So one can get a silver plan, and normally it will cover only 70% of your health care costs. However, once you add in the subsidies and the cost sharing, it can cover up to 96% of your health care costs, making a silver plan better than a platinum plan in some cases.
Mm-hmm. Yeah, no, that's a very good point. I think a lot of people forget about the financial assistance that is available to folks based on their income. The big problem is if you don't make at least 100% of the federal poverty level, you're not eligible for any of that assistance, and then those plans are very much not affordable. So thank you, Monique. Have another question here. This one's kind of for everybody. I'm going to start with Judy, though. Judy, what advice would you have to give attendees about actions they can take to help push Medicaid expansion in the states that are yet to expand? And maybe Jen, if you want to comment, or if everyone wants to comment after, but we'll go Judy and then Jen.
Great. That's a great question, and I think it's on top of everyone's list. I would say, here at the Center on Budget and Policy Priorities, we are working in partnership with several national organizations and many people in the states. And in most of the states where I think in all of the states where there is an active conversation, and that is all of the non-expansion states, there are pretty broad coalitions that are working to close the coverage gap. So my very first top advice would be, if you're not involved in those efforts already, to find out who's leading the way. Often it's a consumer health group. If you don't know how to find that out, just email me and we can find that out for you. And I think that's really the easiest way, because this is only going to be accomplished by a broad coalition. And in many states, hospitals and people that, we may not work with on a day-to-day basis, insurers and others, are parts of these coalitions, or at least part of the strategy. They've got, maybe they're acting in concert in some way. So I think that's really the thing everybody needs to do. We can't go it alone here.
Mm-hmm. Okay. No, thank you so much, Judy. And also, if you want to know more about who to work with, you can also email me or check out our website on the council's website. This is not HRSA approved, but we definitely have a lot of advocacy materials on our site as well. Jen, do you have any thoughts about suggestions for how people might be able to get involved to get their state to yes?
I would definitely say that building coalitions is key. You cannot be the only voice in the conversation, and that it needs multiple perspectives in order to push things forward. I would also say that there's lots of conversations around whether you make the hearts and minds argument for Medicaid expansion or whether you make the economic benefit argument for Medicaid expansion. And I would say that you need both, and that people do listen to both, and that one doesn't negate the other, and together they're even stronger.
Mm-hmm. Okay. No, that's fantastic advice. Thank you. And again, I would just second and third that there are a ton of resources and opportunities out there, at the center, at the council, and many other organizations. So if that is an issue that concerns you and you want to learn more about what's going on, please do reach out to us. I'm going to send this next question to Monique. Those without coverage might be concerned about getting fined under the individual mandate. Can you say what people need to do to make sure that they do not end up getting fined because of that issue?
So for individuals, there's two parts. If you are eligible to get health coverage in your state, so if you're making $40,000 a year and you just choose not to get an insurance plan, yeah, you will be facing a fine. So just educating clients about that is most important. Now, for those clients who fall below 100% of the federal poverty level, that is a large concern for them, because they hear all in the news and the newspaper, oh, if I don't have health coverage, I will be fined. The thing is, when you file your taxes and you're not making the amount that you need to make, you will not face a penalty for not having health coverage, because in your state, if Medicaid has not expanded, then there's no option for you. So I think the key point to that is to just make sure that you're educating your clients about the fines or not having a fine, or their options in general. If they're eligible, they need to get signed up, they need to get enrolled. And I have actually had individuals who have elected, I'm not going to get health coverage, I don't need it, I'll just pay the fine. And that's fine. They can do that.
Mm-hmm. Okay, and just to be clear, if you're under 100% of the federal poverty level, is there anything you need to do, or are you just okay if you're in a non-expansion state?
There's a hardship exemption that an enrollment staffer can help you fill out, and you just send that in.
Okay.
And
I'm sorry.
when you file your taxes, yeah, a little sorry. When you file your taxes, if you're filing taxes, because I found that a lot of individuals, they're just not making any money, so they don't qualify. So the fine comes when you file your taxes.
Yep. Okay. Yeah, that was my understanding, was if you make so little that you don't have to file taxes, and you don't even need to fill out an exemption form. But just wanted to clarify that. So, we're coming up on the hour. So I think we're going to close the Q&A there. Again, I really want to thank all of our great presenters, and thank everyone for attending the webinar. Again, this was Living and Working in the Coverage Gap, Homeless Healthcare in States Yet to Expand Medicaid. And lastly, I'd also like to invite everyone to visit the National Healthcare for the Homeless Council website for future in-archive council webinars, policy briefs, and all sorts of other educational and informational products.